Dear students, a good day to all of you. This lecture from the dental subject comes to you from Department of Orthodontics and Dentofacial Orthopedics. This is the second lecture for you from this department, which will teach you how you are going to diagnose the teeth which are abnormal and the jaws which are abnormal along with facial deformities. As the name of the department suggests that it's an orthodontics, ortho means to correct and dontics means the teeth. All of you have seen the braces on the teeth where those who have been put for the alignment of the teeth. Now we are going to see about the diagnosis of these deformities, how to correct them, and which are the resources and appliances, so that you will get familiar in introduction of the same. We will now share with you the PowerPoint presentation on diagnosis of malocclusion and its effect on aesthetics, beauty and correction. Now coming to the department, as I already mentioned you that it deals with the dentofacial orthopedics. That does mean that slide more over here second. So this is the department of an orthodontics and dentofacial orthopedics, where you will learn about the diagnosis of malocclusion and its consequences and aesthetics and the treatment modalities. Now, generally the assessment of malocclusion or diagnosis has been done either by the general dental surgeon or general medical practitioner. You, being as a medical practitioner of future, should know that I will able to diagnose what are the abnormalities in the teeth, especially in a growing individuals or in those in adult life also. Nowadays people are quite demanding about the facial beauty and aesthetics as part with their age. Now when you do the intraoral examination, you will find that the teeth are not aligned well. In a first picture on the right upside, you can see that they are coming out. Some of them they are overlapping each other, while some of them they show the spaces in between. So these are the terminologies in scientific literature are in form of patient chief complaint. These are the protruding teeth, or these may be a crowded or crooked teeth, or these may be a spacing in between the teeth. We diagnose this as malocclusion. We term that it is an dentoalveolar proclination, dentoalveolar crowding and dentoalveolar spacing. So such type of the deformities, that is departure from normal occlusion, is considered as malocclusion. That means though there is no severe pain, there is no swelling, no any obvious signs of inflammation, still the patient has got a complaint that I want to look beautiful, I want to improve the position of the teeth, I want to see that I look much more better than my siblings or colleagues and in society too. When you view the tooth, you will find that sometimes the size of the jaws is too large and the size of the teeth are too small. So in the first figure, you can see that when the teeth are smaller in size as compared to the size of the jaws, they ultimately lead to the spacing. You can see a gap in between. It also be possible when you have got a large tongue which flares the teeth out. It is also possible when your tongue is not behaving well during swallowing. If the tongue protrudes out, it takes the teeth out, and that is known as flaring of teeth due to the tongue thrust. So, malocclusion, the basic etiological factor is an heredity. Apart from that, it is the environmental factor which impacts the malocclusion. Now you will ask me what the role of heredity. All of you know that most of the time a child looks like a mother, or child looks like a father, or child may be an hybrid product of both of them. Some of the feature he will take from the mother, some of the features he will take from the father, and he will show the combination. Now, if you apply that principle to the jaw size and tooth size, some of the time a child takes the jaw size from a father and a tooth size from a mother. Now, when these small teeth are arranged on a larger jaw, they lead to spacing. Vice versa, many of the time the child takes the jaw size from the mother and tooth size from a father, a large teeth over a small jaw. Either they overlap each other, which is known as crowding, or they come out of the arch or out of the face, which is known as protrusion, which is obvious in the next figure, which you can see. So this is known as disproportionate total tooth material and basal bone discrepancy. Here the basal bone is maxilla and mandible. Most of you have faced such type of the malocclusion in your childhood, which you may have been corrected by taking the help of dental surgeon or an orthodontist, but many of you still have such type of deformities where you can do it as a self-diagnose, and you can come to the department of an orthodontics for correcting the same. Now, this is obvious extraorally also. When you look a child or a young adult or a young individual from a long distance, you will find that there are many facial types. Many of them, they have got a long and narrow face, while some of them they have short and wide face, while the average one are the combination of these two. The individual who has got a very long and narrow face, we term this as a long face syndrome, while the one who has got a very short facial height, we term it as a short face syndrome. The characteristic of the teeth which has been arranged in the jaws of these individuals is also has got a profound impact on face and facial height. In long face syndrome, you can see that the lower facial height has elongated a law, resulting into the protrusion of the tongue in between, and we term this as an open bite, where you can see the picture of the tongue or a space in between the upper and lower teeth when we ask the patient to chew on the back tooth. Vice versa, when it comes to short face syndrome, the facial height is too small and we ask the patient to bite and check, you can't see the lower teeth. We call this as a close bite. We called it as a deep bite. So, we are the one who diagnose it properly. Now, all of you have read the role of adenoids and tonsils in airway development and in causing the adenoid facies features. In adenoid facies, when you go to an ENT reading, you will find that the jaws are, face is long. The patient keeps the mouth open through breath into the oral cavity, which is not the function of the oral cavity. You will see a very long and narrow deep palate. You will see that the features, when you examine the tonsils and adenoids, they are of larger in size in a growing individual, especially in prepubertal and pubertal phase. Likewise, when you learn about the sleep disorders, when you do the sleep study, when you will learn about obstructive sleep apnea as a syndrome, you will find that we are the one who help in diagnosing the case, we are the one who help in correcting and formulating the team for pediatric as well as adult obstructive sleep apnea by giving them a proper appliance which reposition the jaws, restore the airways and helps the patient in proper breathing. Now, there are many types of malocclusion which you can notice. The first two extraoral photographs are there in front of you. The first photograph has got a convex face, while the another girl has got a concave facial profile. Looking from a distance, you can diagnose that this boy has got prominent mid face and deficient lower face, while girl has got deficient mid face and the prominent lower jaw. We term this as a convex and concave facial profile. When you come across such type of the deformities, either in growing individuals or in those who have actually become an adult, you can say that this is a malocclusion and need the consultation of an orthodontist and a specialist dental surgeon. In a first figure, you can see that the teeth are protruding out, the bite is quite deep, while in second figure, you can see that the lower teeth are coming in front that of the upper jaw is smaller, the lower jaw is larger in size, and this is known as a reverse bite, reverse jet, and this is also known as a cross bite in terminology of dentistry. So, how you will identify the malocclusion is of crucial step. You need the help of your friend as a dental surgeon, or at least you need to guide the patients reporting to you with these complaints that you need a specialist consultation. Now, we have discussed that along with facial features, there may be the deformities in the teeth. Maybe the face may be a normal extraorally, but when you go inside the oral cavity, with the help of an instrument known as a mouth mirror, a small round mirror where we examine the teeth. Many of the time we find that the upper teeth have gone inside the lower teeth. So this is known as cross bite. This may be in a front region, this may be in a back region. When it is in the back side or when it is restricted to premolar molar region, we term this as a posterior cross bite. When it is restricted to incisors and canines, we term it as an anterior cross bite. Many of the time, the alignment of the teeth is such that the upper teeth they come out and the lower teeth they go inside, and this is known as increase in the jet and bite. These are the common terminologies: overjet, that is horizontal overlap of teeth, and overbite, that is nothing but a vertical overlap of teeth. Now, the next question is how we diagnose this deformity as a malocclusion. All of you know that how we can define a diagnosis. It is nothing but an art of identifying the disease by listening to the symptoms represented by the patient and signs observed by the clinician. But as far as facial beauty, the smile analysis, the complaints related to the malocclusion are concerned, the patient values and preferences they include: my teeth are irregular, my teeth are coming out, my lips are not closing, I am not looking good while smiling, my gums are visible, and I can't bite properly as there are teeth which are irregular, I can't brush properly because of irregular teeth, I can't keep my oral hygiene properly because of these teeth. So these are the chief values of the patient's concern once he comes to the malocclusion. He doesn't have any fever, he doesn't have any pain, he doesn't have any swelling. You will not see the classical signs of inflammation like dolor, rhubarb, everything. Here the patient is physically alright. Here the patient is sometimes mentally disturbed because of the look and aesthetic. It is psychosocial trauma for him. And then to diagnose, we have to take the case history. Then we have to go for clinical examination. Then we have to make an impression, fabricate the model's replica of three-dimensional analysis. Many of the time we record the radiograph and we record the photograph also. But the most important is case history, which we can't ignore. In case history, beside the chief complaint which has been recorded in patient's own words, when you start asking about the history reveals the important clue on the etiology of malocclusion. If we say that, are your brother and sisters are looking same that of you? He says yes. That means it may have got an heredity in origin. And the next one is that when you do the case history and clinical examination, we sit the chair side. We ask for the family history. Are your mother or father are looking like you? Are there any history of past medical disorders or congenital deformities like cleft lip and palate? Or do you have some past history of dental extraction or history of trauma? That has to be noted, because all these factors, they play an important role in management of a disease. The next one is clinical examination. Usually this clinical examination is being done in dental chair, where nowadays because of COVID pandemic, you are well equipped with COVID protocol, which includes the face mask, which includes the face shield, which includes the hand gloves and sanitization, and everywhere these COVID protocols. When you start examining the patient, you have to examine the patient clinically as a whole, that general body posture, the physique and everything, height, weight, everything. But the main concern lies with an extraoral examination as well as the intraoral examination. As the name suggests, in extraoral examination, we assess the forehead, we assess the eyes, we assess the nose morphology, we assess the lip size, we assess the lip posture, we assess the lip function, we assess the chin, we assess the ear, we assess the facial proportionate in vertical and horizontal dimension. But as far as intraorally it is concerned, extraorally also we do some functional analysis. In form, we do the assessment of temporomandibular joint, a joint which joins the lower jaw to the base of the cranium. We do that analysis also. What do you mean by functional analysis is that we are dealing with a system known as stomatognathing system. You may get a short note on stomatognathing system. What does it mean? This is a structural composite which consists upon the teeth, the jaws, the tongue, the surrounding musculature intraorally as well as extraorally, which formulate an apparatus which helps in mastication, which helps in speech, which helps in deglutition, which helps in respiration. So these are the functions of stomatognathing system, and when you assess the functions like mastication, deglutition, speech and respiration extraorally, the analysis is known as functional analysis. Then many of the time, in absence of patient, we capture certain images of the face extraorally and certain images of the teeth intraorally, and we perform various photographic analysis. There is no need in depth going through you as an photographic analyst, but you should know that the photograph can be used as a diagnostic tool in absence of patient for a longer period of time. These photographs These are two-dimensional records of the patient in different posture, which helps you in diagnosing the case, which helps you in assessing the progress of the case, which helps you in assessing the patient's values and preferences, so that you can design a treatment plan for the patient which will benefit to his chief values and preferences, which will minimize his treatment duration, which will minimize the treatment cost, and which will give you the maximum benefit to the chief complaint, and this is known as risk benefit ratio analysis. After the photograms comes the most important diagnostic tool, an essential diagnostic tool, which is nothing but radiograph. These radiographs, they may be in form of two-dimensional pictures like lateral view of skull or the circumoral view of the teeth and the jaws. We as a dental surgeon has got a special radiograph known as orthopentomograph or a lateral cephalogram, which has been recorded in a special equipment which has been made for them. Now, these radiographs, they help you in assessing the size of the bone, the length of the bone, the width of the bone. Bone means maxilla and mandible, and its supporting structure. They also help you in assessing the size of the tooth which is there inside the mouth, the size of the tooth which is there inside the jaw, and many of the time they help you in assessment of abnormally positioned teeth and normally positioned teeth. In radiograph also, nowadays we have got an additional three-dimensional tool which is known as cone beam computer tomography, that is CBCT. It is a three-dimensional diagnostic tool available with us. The next one which you commonly see in dentistry, these are the plaster models of jaws. They are low cost, they can be made at any place, they can be stored for a longer period of time, they can be used to study the position of the individual teeth and the group of the teeth one over the another in one jaw or in other jaw or in corners with the right and left side of the jaws. So these study models, they help us an diagnostic tool to perform an analysis which is known as model analysis. Most of the time your dental colleagues, they carry the models along with them in the hostels. They measure something with the vernier calipers or the divider and scales on the mallet and write the value. What they are doing is they are doing the model analysis. In model analysis, we measure the size of each and every tooth. We measure the size of the bone which is supporting the teeth. We measure the depth of the palate. We measure the arch width, that is maxillary arch width, mandibular arch width. We measure the arch length, that is maxillary arch length and mandibular arch length. We measure the arch height, whether it is a maxillary height or mandibular height. So these study models, they are the three-dimensional replicas of the jaws in absence of patient, where you can study them and come to certain conclusion that whether you can solve the chief complaint of the patient properly with an appliances. The appliances are nothing but mechanical devices, maybe of removable in nature, maybe on fixed in nature. These fixed appliances, they are usually the brackets which you see that we stuck on the surface of the teeth. They may be of steel type, they may be of ceramic type. Now coming to what leads to malocclusion. Why it is so prevalent in modern society? Imagine the dietary habit of our primitive tribes. Learn the science of anthropology, learn the science of human being, learn the science of evolution of human being. Our ancestors, hundreds years back, 500 years back, 1000 years back, they used to eat a very rough, tough food. a partially cooked food or uncooked food. They used to chew that food with their teeth and jaws. Their musculatures were strong, their jaws were of larger in size, and this all is you will learn when you will come to the science of anthropology learning. This is a special chapter on it that is known as Stone Age man's dentition. The malocclusion was not that prevalent in that society. The teeth were quite aligned because the size of the bone was optimum, the muscle strength was optimum, everything was normal. But with the evolution, we have changed our social status, we have changed our dietary habits, we have changed with society, we have the behavioral changes, we have the nutritional changes, we have the changes how we eat. So compare the today's generation eating the very soft, refined, highly cooked food. The person who doesn't have a single tooth can be a healthy or can be a obese or can be a overweight because he had chosen the fast food. He had chosen the refined food. The functions of stomatognathtic apparatus have gone away. Then they don't need the teeth to bite them. You prefer drinking the juice rather than eating the raw fruits and vegetables. You prefer eating the pizza, burger and the refined fast food rather than going to a traditional food which your grandmother used to cook in the house. So this is lead to an etiology of malocclusion which has become more prevalent in today's generation. Now, the most commonest etiological factor is heredity. Heredity, that means gene, genetic inheritance. All of you know that at the time of fertilization, a single cell sperm unites with a single cell ovum to form a zygote and carries the genetic coding of a father and mother equally or predominantly from one parent, and this type of the heredity, the genetic inheritance, gives the similarity in the look of the father or a mother or a combination of both. There may be similarity of the jaw size, there may be a similarity in the teeth size, there may be a similarity in smile, there may be similarity in the facial height and the height of an individual and so on. So, heredity plays a strong role in causing the malocclusion. Next is the trauma. Many of the time when you are posted in gynecology, we do the forceps delivery, we do the cesarean section. That time, obstetrician, they do a lot of pressure on a face and head coming from the uterus. If any trauma leads to the trauma to the lower jaw or to the growth centers of the jaws, they may be in form of the mandibular condyle or a nasal septum, and that leads to a deformity known as traumatic injury, which ultimately affects the size of the jaws. There are many abnormal habits, like sometimes you find the child is sucking a thumb, sometimes you find the child is sucking the lip, sometimes you will find that the child is thrusting the tongue out. So sometimes you find that the child is clenching the teeth or causing a noise during the night known as a bruxism. Sometimes the child is keeping the mouth open known as a mouth breathing habit. So all these habits, they lead to malocclusion, and you need to break these habits by your treatment intervention. Many of the times certain diseases or the congenital facial deformities in form of the Down syndrome, Treacher Crowley syndrome, cleft lip and cleft palate, malnutrition, malnourishment, all this protein energy malnutrition leads to the diseases which are resulting in the lack in the growth of the jaws and teeth, and ultimately it leads to the developmental defects of known and unknown origin. So the etiology of malocclusion is multifactorial, basically heredity plus the environmental factors after the birth on which the child is developing during till the puberty. Now, as a medical practitioner, you should know that this malocclusion is associated with certain serious illness. Many of the time the patient comes to you with a headache, vertigo, lack of proper sleep, snoring. Then he says that suddenly I wake up during the sleep, I can't breathe properly. These are the cardinal clues for obstructive sleep apnea, which you will learn more in depth when you will be a medicine student. You will learn in depth when you will be posted in ENT. There, when there is any obstruction in nasal airway resulting in disturbances of sleep, known as obstructive sleep apnea. Now, it may be observed in pediatric patient nowadays, known as pediatric obstructive sleep apnea. It hampers the quality of life. Daytime, the child or a young adult feels sleepiness, sluggish, he is not active, he doesn't get a proper sleep, and that is diagnosed with polysomnography. Now, once we say that it is an obstructive sleep apnea, we as a dental surgeon, or we as an orthodontist, or we as a craniofacial growth specialist redirect the position of the lower jaw more in a forward position. We re-establish the airway, we re-establish the dimensions of the nasal and pharyngeal airway, and we help in solving the problem of the patient in sleep disorders. We term this as a dental sleep medicine. So please don't ignore your friend who will help you, a practitioner, a colleague, that it is a team approach. You need an craniofacial growth specialist and orthodontist to treat the obstructive sleep apnea. Call him, sit with him, diagnose the case and take the help of him. The next commonest disorder is cleft lip and palate. Now, all of you know that this is a congenital deformity affecting almost 1% of the individual in the India, where you can see right from the birth, these patients, they have got clefts in the lip, clefts in the palate, and ultimately that lead to facial disfigurement and trauma, and they get a disturbed speech, they get disturbed jaw growth, they get disturbed beauty, and this again become a team approach along with oral surgeon, orthodontist, ENT, speech therapists, and so many other individuals to lead as a team leader. So you are one of the team leader as a general medical practitioner to diagnose the multifactorial etiological syndromes and symptoms represented by the patient related to the face, oral cavity, and the functions of oral cavity. They are nothing but chewing, known as mastication, swallowing, which is known as deglutition, breathing, which is known as respiration, and talking, which is known as speech. So these are the prime functions of stomatognathing system. The more specific syndromes are associated with malocclusion. We need not have to go them in depth as they are very rare, but you should know that when you are dealing with such syndromic cases, you may need a help of an craniofacial growth specialist and orthodontist. The syndrome may be Perry-Robin syndrome, the syndrome may be a Treacher-Collins syndrome. The syndrome may be a Golin-Ghost syndrome, or syndrome may be acrofacial dysostosis. So these terminologies and these syndromes are associated with the deformities in the jaws and teeth. The more is hemifacial microsomia, the Hallermann-Streiff syndrome, and so on. So all of you should know about these syndromes. Most of the time you may get a short note on craniofacial syndromes. So you need to enumerate them, you need to enumerate their clinical features, and you need to write about the treatment modalities available with these syndromes. There are n number of syndromes which are available, which you should know them in depth. Now the next is that I already explained you looking not good, losing confidence, not smiling properly, not have a proper speech, looking ugly lead to psychosocial trauma in the child. The child loses the self-esteem. The child loses the confidence in the classroom. The child loses the confidence in the peer group, and there the child shows that some behavior malformation and psychological disturbances. So this is known as a concept of how the psychologies has been disturbed because of the look. Now this psychological aspect, the self concept of the child, maybe parents, they expect the child to look good, especially a mother. Always she is a caretaker for the child. She wants the baby to look good. She wants to look the baby more beautiful. The child should have a smile. Then the family members, they may be siblings, their grandparents, uncle, auntie, or where you live in joint or nuclear family. These family members, they give a pressure on the child that go to a doctor or take a mother and parents to the doctor, consult and get yourself treated for your look. Many of the time it is the physical state of the individual because of some syndromic, a biological development, maybe a lack in the development, maybe of late puberty, maybe an impact of the social media like audio-visual medias, the radios, then the school demands from peer groups, then the religious look. Many of the time the Chinese people, they want a long chin, so this is a religious look. Then opinion from the peer group, then family, socio-economic status of the family plays an important role because it's a costly affair. Larger family size, the lower socio-economic group, they can't afford this costly treatment, so they need some help in proper social and psychological development. So it is the attitude of the medical practitioner how to look to the malocclusion and generate the awareness amongst the dental surgeon and towards amongst your colleagues that I can treat the cases. Let us see few of the case report. Let us see a small boy of 7 years. He complained with us of a protruding teeth. What we have did is that we have just prepared certain block of the composites on the tooth surface and guided the growth of lower jaw, and 1 year post-operative he was looking quite well. A simple modality. We just guided the lower jaw in a proper position, and that has improved the self-esteem of the child at a younger age with minimum cost, with maximum benefit, with minimum risk, with no cost at all. Take a next case. See how the girl looks. She has got protruding teeth. She wants to improve her smile. We have given certain appliances made of a wire. We have anchored with that some extraoral devices which are known as extraoral orthodontic appliances, and we modified the growth of maxilla and mandible, and the same girl was looking much more beautiful the post appliance. These were the growth modulating appliances. These were the changes in the face of that young girl which has caused, when he started using these growth modulating devices, that had changed the positioning of the jaws, that had changed the growth of the jaws, that had changed the beauty of the face, and she looked much better than previous. See the improvement in the smiles, improvement in the self-esteem, improvement in psychology, improvement in the social well-being. This is the miracle of an orthodontist. Take a next girl. Again, very narrow upper arch, protruding teeth in a middle prepubertal group. Again, we have given some appliance in screw form to widen the growth of upper jaw and supported with the plastic tracks, and she have developed a nice upper and lower jaw in 3 dimensions, and this is how she has improved pre versus post. You can see a young boy, prepubertal boy, where the lower jaw is deficient, the upper jaw has gone forward, leading to the protruding teeth. We have given an appliance known as functional appliance. No need to remember it. We have fixed it on the inside the oral cavity, and that has helped in correcting the jaw discrepancies in 3 dimensions. And see how the boy is looking, a young adult with a straight face, with improved in facial height, improved in jaw posture, improved in smile, improved in beauty. So I, as a Dr. Thoshinwal, professor and head from the Department of Orthodontics, has illustrated you that how we can change the facial smile and beauty, how we can diagnose the case of a malocclusion, how we can take a help of an orthodontist in a team approach, and how we deal with such type of deformities. Thank you for your patience listening to this YouTube. Thank you so much. वाकडे चाळीस मिनिटं झालं.